Welcome, everybody. It is Thursday night, and we are here with my wonderful friend, Nicole Archambault. How are you, Nicole?
I'm great, Renata. Thank you so much for having me and for everybody kind of tuning in after a long day. So thank you.
Did I say your last name right?
Yeah, it's Archambault.
Archambault. I have been practicing.
Yeah. No, it's so close. Trust me, I've heard so many iterations since I was a little girl that you came very close.
I'm the same way. So I usually tell people it's Nami, like tsunami, without the su. It looks like Nimi or Nahim. I've gotten everything, but it's Nami. Awesome. Yeah. Okay, so guys, I'm going to introduce Nicole first. Nicole is an ASHA certified speech-language pathologist, orofacial myofunctional therapist, certified youth mental health specialist, certified sleep science coach, breathing reeducator, and airway advocate, and certified lactation education counselor. She is the founder of Allspace Therapy in Los Angeles, California. Nicole is currently serves as a secretary for, oh my goodness, somebody call me? Oh no. Somebody sharing their screen, is that me? Okay, I think we're back. Where were we? Nicole currently serves as a secretary for the Academy of Applied Myofunctional Sciences and is the myofunctional therapy section leader for the American Academy of Physiological Medicine and Dentistry, the AAPMD. She is also a graduate of the Mind-Brain Teaching Graduate Certificate Program at Johns Hopkins University. Nicole is a national and international speaker, as well as a published author on the topics of educational neuroscience, orofacial myofunctional therapy, airway functional disorders, and the autonomic nervous system, as well as sleep wellness in pediatrics. Her first article for the ASHA Leader 2015 on sleep disordered breathing and tongue ties garnered a Bronze Excel Award from Association Media in Publishing for Best Column. Nicole is a passionate advocate for interdisciplinary collaboration and public health awareness on airway health and sleep, alongside an interdisciplinary team of colleagues on the FAIREST Functional Airway Evaluation Screening Tool. She has contributed to research on nasal breathing screening and tongue mobility published on the International Journal of Otolaryngology. You guys correct me, I can't say it. And the Journal of Rehabilitation, respectively. Nicole, we are so excited to have you tonight. The topic is moving beyond the ties that bind us, essential factors for optimal release timing. So the floor is yours. Welcome to Airway Circle.
Thank you, Renata. This is my first time here, and I'm excited to be with all of you. And I know we're so many like-minded people here. So thank you for your introduction. My really fast way, my new way, sometimes I say it's my lazy way of introducing myself is to talk about my I ams. And I am a speech and language pathologist. I am an advocate. I am a connector. And some of those other things that Renata listed. And I'm also a mom, last but not least, I'm a mom. And what I really have come to say for a very long time now is that I'm an onion peeler. I can admit to that. I am all about peeling back the layers of the onion because I think that we're all onions. I think we're all very layered. And when we start our diagnostic processes so that we're not just treating symptoms, I think we're all in that process of unlayering. And sometimes we recognize that we come to a space and we need to refer out when we've peeled back a layer. Sometimes we come to a space with kids and we realize that we need to hold the space, right? Before we move too far, we just need to stay in the space that we're in. So I invite all of you to be onion peelers as well. Really, I feel very passionate that children are so much more than their mouths. And, when we, as oral health professionals, and for some of you maybe who aren't oral health professionals and are coming in, or maybe your parents, we often notice this outer landscape first. But it's accompanied by this very rich internal landscape. And when we can recognize the external and the internal landscapes, how they integrate together and the influence of the environment, we really can see the whole child. And I believe that this is how we go beyond form and function as we know it. So a little story, my why. Why in the world did I ever do a lecture on this? Why is Renata having me here tonight to talk about this? I think like many of us, we are compelled by our personal and professional experiences. And a few years ago, I was treating a 4-year-old little girl who was a twin, and she had a twin brother. She had an older brother. And this little girl had an upper lip tie. She had a tongue tie. And it was decided that she would have those releases done separately. She was also a little girl whose mother very freely in front of her told me that her dad did not want her or her twin brother. She was also a little girl who went home and told her mother that I treated her on the roof of my office. So her mom, being a diligent mom, called me to ask me, did you take Annabelle to the roof for therapy? And of course, I told her, no, I did not. But I also asked her if these kind of stories were happening, and they were. So she was a very layered little girl. She was also, for a 4-year-old, mentally very tough as nails, and she did not like to ever show a weakness or if anything bothered her. So lo and behold, she has her upper lip tie done. There's no serious, red flags that we're not going to do well when it came time for the tongue tie release. And she was released. The releasing provider hadn't seen her back. I wasn't seeing her. It was almost like, oh my goodness, what's going on? So by the time this little girl comes back into my office, I sat with her, and her mom just shamed her so badly that she sat there with these tears just streaming down her face. And of course, what do we do in that moment as therapists? You put on the biggest cheerleading skirt that you have. And it was, hey, you've done so much work, and we're all here to work together and move forward. But as a clinician, that experience really bothered me. And to the point where when I went home that night, I really asked myself, do I want to do this anymore? Do I want to play in a space where we shame children when things don't go our way in the adult world? So obviously my answer was no, I'm not quitting, because that's not a solution. But it really, was the impetus behind what can I do as much as I can as a child and families therapist to avoid these types of situations in the future, right? So that's kind of how this approach came about. It was my heartfelt reaction to something and a lot of thinking. So I kind of want to start by asking all of you, who are your patients? And I'm going to ask you to think about it. And then I'm going to give you an answer as to who I think all your patients are, which sounds crazy because I'm not in your practices. But I think our patients are the hardest patients we've ever had in history. And if you guys, I know we've all been tuned in and out during the pandemic of the last 2 years, but back in December, the U.S. Surgeon General actually issued an advisory warning of a devastating youth mental health crisis as depression and suicide rates were on the rise because of COVID. Okay, and that these experiences in the pandemic, at home, in school, and in the community were having really this huge impact on children's mental health. And this is important to consider for tonight's lecture because it's connected into the autonomic nervous system. The interesting thing is we had all kinds of data before the pandemic that this was there. So it's, you could look back to the research on obstructive sleep apnea in 2018, and there was a connection in teenagers to suicidal ideation. All of the numbers in terms of anxiety and depression that we were already seeing in kids just kind of skyrocketed during the pandemic. So in light of that, what I've been kind of speaking on the last few years is the limbic system. And I like to call it now limbic lockdown, because I think we all know what lockdowns are. And it's really looking at children from the space of where they are in their limbic system. And if they are in their limbic system, that neurophysiologically prevents kids from getting into their prefrontal cortex. Okay, and I talk to children about this in terms of their downstairs brain and their upstairs brain, because they seem to get that concept, which I can't take credit for that concept. That was from Dan Siegel and Tina Payne Bryson out of UCLA. But children respond well to it. So all of you working with kids with airway function disorders, be it mouth breathing, be it sleep disordered breathing, upper airway resistance syndrome, OSA, those kids, we're going to go into a little bit of the research on how they're in their limbic systems, okay, and they're stuck there. We know kids with anxiety before the pandemic, 25% of 13 to 18-year-olds were experiencing anxiety, and that at some point, 30% of children experience anxiety. And we know that it's highly treatable, but 80% of those kids are not getting therapy. So why is that important to consider? I can tell you on my caseload and my practice, I have kids upwards of 80% who have some type of airway function disorder, and most of them also have comorbid anxiety. Okay, we know toxic stress puts children in their limbic systems. This certainly, again, this pandemic, living in a sedentary lifestyle. Okay, and sometimes when you think of sedentary lifestyles too, we've got to kind of think a little bit about technology and that tech neck. And we're, in some cases, we're compromising further airways that are already compromised when postures are not appropriate. And then we have kids with retained primitive reflexes and sensory processing disorders, children with special needs. So if you're thinking as a clinician and you're thinking of your intake, these could be, questions, or you probably have them on your intakes in terms of what's going on for some of these kids. I'm going to touch on parenting styles tonight, and also the fear of failure and the fear of failure that children now have. Alrighty. Renata, you disappeared, but I think you were trying to disappear. Okay. I feel like I'm talking to myself.
I know. Do you want us to be? I know.
You can totally be my face, because honestly, when all of us present, this too, like you find those certain faces. So if you want to keep the face, because otherwise I just get this white symbol of a human being, and it's far more pleasant to look at your smile.
Okay. As long as we're not in the way.
You're not distracting me, and you make me feel like you're all out there and I'm not just speaking to the air. So thank you.
We have about 60 people listening, y'all.
Okay. Hi, guys. Guys and gals and everybody else. So I really think, and I feel like maybe all of you might agree with this, because we're all in this similar field working in our teams, but release is a gift. It really is. For some of these kids who've never had these oral functions in place, or that don't have optimal oral functions or good nasal breathing, this is really an opportunity to give a gift to children and their families. But what I also want to say is your patient ready for the wound? Right? Is your patient ready for the wound when they're in their limbic system and they can't get to the prefrontal cortex where they need to be to problem solve, to attend, and to self-regulate? Not just in those 3 weeks post frenectomy, but also in the lead up too, right? And I'm not going to go into a lot of this right now, but if you look at some of the research on wound healing and the autonomic nervous system, having kids in their sympathetic nervous system is not the best place to move forward in terms of trying to help heal wounds. So I think that, what's really important, and I've heard this before, well, they've got a tongue tie. We just need to get it released. Or I've also heard the expression, when in doubt, cut it out. So I really feel like there is this huge difference between needing a release and knowing when a child is ready for release. These are two very different things. And knowing that difference is really dependent upon the degree to which we're really willing to expand our clinical lens? What are we willing to look for outside the normal structure and function? So I'm not going to go through with you guys tonight, like any types of protocols. You probably are using them. You have your teams. You're all determining when there's a tongue tie present. But we're going to talk a little bit about some other essential factors, is what I call them this evening, that can help us figure out when is the most optimal time for release, right? Because we want to use this integrated lens, because the idea is that we're helping patients achieve optimal outcomes for really, better health and function across their lifespan. And we want to set them up for not just success in our therapies that we're doing around the times of these releases, but also for other interventions they may be having down the road. We want to set all of our teams up for success, and we want to really avoid creating unnecessary traumas for children. And some of those we can avoid by just getting the timing right. And I think that by using an expanded lens, we really avoid practicing in any way that erodes public trust in us, right? We've all heard, oh, this is a fad, or we've seen certain articles that shall not be named that are out there. And none of us here in this circle or in this space are trying to contribute to that in any way. I think if anything, we're just trying to contribute to a better standard of care. So my lens is really informed through what I call a space to grow framework, which is looking at head space, mouth space, heart space, and body space. And tonight I'm going to go into more of like that head space, where we create an optimal head space through physiological balance and neurofunctional integration of the limbic system and the prefrontal cortex. So let's go back to our airway kids a little bit. Okay, I think the impact of airway issues on the autonomic nervous system is really it is their plight, and we want to really think about what repetitive hypoxia does, how it alters function of the autonomics, right? So you have the two branches. You have the sympathetic nervous system, and I apologize, guys. I'll just review this quickly. You all probably know this. It's that fight, flight, or freeze. And we have the parasympathetics, which is rest or digest. And I really like to think about them as a gas pedal and a brake pedal, because you don't want to totally take a sympathetic nervous system offline, because that's what keeps us alive. And that's the body's job, right? But we want to have a better balance. And we don't want kids predominantly living in that fight, flight, or freeze mode in this limbic lockdown. So they've actually done studies looking at heart rate variability in children with obstructive sleep apnea and sleep disordered breathing. And they found that children experience this overflow of activation of their sympathetics and a deactivation of the parasympathetics. But what's really important to consider is that they found that this kind of bled over or carried on into the daytime. Okay, so children will look a certain way when they're in that sympathetic nervous system predominantly, and more so than parasympathetics. One of the things that I think is really important is not just considering their functioning in terms of their autonomics, but also where their parents are. So, we can all think to, as an example, breastfeeding patients and tongue ties, and we talk about dyads. So what I would actually like to invite all of you tonight to do is to kind of shift into what I call the triad. And really what we want to do is we want to increase this mental space to accommodate this movement. Because when you look at a triad, it's your patient, it's the family, that caregiver, and it's also us. Okay, because we know that children regulate off their parents. Their parents come to us and they're regulating off of us. As teams, when we get together, it could be in person, it could be on the phone, we are regulating off of each other. So we want to notice how everyone is showing up. And this isn't a lecture tonight on how to focus on all of us, but you all know from the things we give to our patients to get them into maybe this better space in their autonomic nervous systems, we need to be doing the same things for ourselves. So I can't really, I don't usually give disclaimers, but I'm going to give a parenting disclaimer tonight because I'm going to talk a little bit about parenting styles. And I think I mentioned that earlier. But, without a doubt, parents are the most important person in a child's life, right? And, I'm going to talk about some things, and it is not in any way meant to dishonor parents. I'm a parent. It's the most rewarding job. It is also the hardest job. And I just really want to put some, just some awareness of behaviors, the adult behaviors that really have a potential to impact our interventions. So if we think about, hopefully you've all heard of various parenting styles. I have one now that I call the tornado parent. And as it kind of implies, you could imagine just from picturing a tornado that this is a parent that's moving really, really fast. I mean, literally, I thought I should put up speed limit signs in my clinic for some of these parents. But really, one or more of their systems run at excessive speed. And we see this, we hear it sometimes when we take an intake on the phone, everything's very fast. They tend to be very goal driven. So they wanted everything done yesterday, and you're going to have everything done once you start in the next 2 weeks, because this is how this works. This is really fast. But the part that's tricky here is that in a parent with that style, and this could be, look, we live in a fast-paced world, right? And their kids are overpacked with schedules, and everyone is really doing the best they can. But they miss the nuances of their child and where they are and maybe what their needs may be in this moment, because their agenda is so far ahead, right? So I really think that to meet children where they are, we have to be in the moment with them. Okay, it's really about being present and helping families to be in that space too. Looking to who's ready for a release. I grew up as a little kid who was quite a perfectionist. And somehow now I get all these perfectionists in my clinic. And I didn't see this so much until I'd say the last 5 years, and specifically more in the last 2 to 3. And as a recovering perfectionist, I identified these kids really quickly. And a lot of that comes from this fear of failure. I don't know if you guys see this in your practices. And I really think we have this epidemic in children where there's this failure aversion, right? And I wouldn't even bring this up, except I've given this a lot of thought because it impacts therapy. It impacts their willingness. If we're thinking about neuroplasticity and how often kids need to be doing something to create new neural networks, new skill sets, patterns, and habits, they've got to practice, right? So in that tornado style parenting, there's not enough practice time, right? Because we're getting it done fast. But there's this fear of failure, and I've thought about it. And so what I've come up with, and maybe all of you will go home tonight and think about this more and come up with your own reasons. But I think it's important to know, because if we can find out why children come in this way, then there's a chance we can come up with some tools or some ways to help them so they can jump over this hurdle and really do what we need them to do in therapy. So like airways, like myofunctional disorders, children being afraid of failure is really multifactorial. Okay. So it can be parenting style, like the tornado parent. Okay. Those kids aren't given enough time to do like a rough draft, is what I like to call them. So if you all think back to grad schools, maybe you're writing professional articles, very rarely is the first draft what you submit. We all go through this practice period. That's what kids come in to do with us, is they start to relearn, or maybe learn, I shouldn't say for the first time, they've all got some level of function, but that's what we need them to do. And we need them to practice, right? To be willing to do rough drafts and to not get it right the first time, right? I think somewhere I heard fail is first attempt in learning, right? So if you look to research I found it in Play, it had to do with helicopter parents. And just in case you all, okay, Renata just raised her hand if all of you didn't see that. Okay, and you know what? It's a label. It doesn't mean people don't use these styles once in a while, but we're really talking about styles right now that are very predominant. Okay, so helicopter parents may be doing, like the name implies, they're hovering. There may be that fear that a child is going to be hurt, or they want to fix something for them. They've also done, there's also snowplow parents, if you guys are aware of snowplows parents. And that parenting style is to push away any perceived obstacle that a child might encounter. Okay, so, well, why in the world does that matter? Because we're removing struggles for children. They're not having opportunities to make mistakes, to problem solve their way out of them. And it's really not, it's not giving them opportunities to take healthy risks, right? And they're not really growing grit and resilience. And how many of you, when you're working with these kiddos, they come in and you're not going to just one day later have all these new skill sets exactly where they need to be, particularly in kiddos that are, that have tethered oral tissues, right? So some of that is we're going to talk about this a little bit later, but realizing that stems sometimes from a parent's, their own discomfort. It's their discomfort in seeing their child struggle, right? But a child that hasn't had an opportunity to struggle has reduced tolerance for discomfort, or what I like to call dis-ease. And we do need them to hang with us in therapy. We don't create new neural networks in 2 days or 2 weeks. We need them there for longer than that. The other thing I think, and again, I bring this up because it's just to think about, like social media. Little kids may not be on TikTok or Facebook or Instagram, but their parents are, maybe older siblings are, and it paints a world that's very airbrushed and tells everyone's perfect, wonderful, lovely stories. So while we may not intend to set this bar really high, I think that has influenced children and coming into the space and thinking they have to be perfect. Because I've literally had kids who want to do something one time and that's it. So I literally bring out a picture of the brain. I tell them, have you ever seen the inside of your beautiful brain? I'm like, look at this. Do you see all these, they're like wires. And did you know that the more you practice, the more they wire up together and they fire and your brain changes. And all of a sudden, these things you think are hard become easier. And then they become really easy. It's like what you did when you learned to ride a bike or when you learned to write your name. All right. We also, screens, digital technology, and I'm going to show my own brain impairment here, but they have literally researched kids with digital technology addiction, and they have compared them to drug addicts, and they have looked in functional MRIs at the gray matter of the frontal lobes, and found that the changes in both groups were the same. The changes to the myelin sheath are the same in both groups. Okay. So obviously this is a little bit of a problem. How can we recognize kids when they're in their limbic systems? In my practice, I do something that really you can observe in a clinic setting. This is not expensive. This is not anything that requires you to hook kids up to machinery or anything like that. But it's looking beyond some form and function. You can look at some physical features, which we're going to go over a little bit. You can look at the behavioral signs and symptoms that a child is showing you. You can look at the sensory, and you can look at language, right? And you guys are all experts in looking at all this physical stuff. There's physical stuff you're looking at every day that I guarantee you are telling you what part of the brain a kiddo is in when you see them. So your mouth breathers, who typically, when you think of people with increased respiration, are typically our mouth breathers, right? They take a lot of breaths per minute. People that are breathing more from the clavicular area, right, versus diaphragmatically, okay? Because when you actually access the lower lobes of those lungs, you're tapping more into the parasympathetics, which you're not doing from breathing up here. So I'm not going to go over this part tonight because you guys, again, you're all experts in this, but there are like, and I could share this if anybody just needed it, but there's 20 signs and symptoms of mouth breathing that we can see in the literature. Okay. Mouth breathing. We thought for a very long time that was benign. It is not benign. Just like primary snoring, that's not benign. We can also use orofacial myofunctional disorders as clinical markers for sleep disordered breathing, right? And as I mentioned in the literature before, you get into sleep disordered breathing, you've got changes and shifts to the autonomic nervous system. I do simple things like, and I guess we all have to be cognizant of where people are with touching these days, but pre-pandemic, I was high-fiving, shaking hands. Do you feel kiddos, are they sweaty? Okay, that's a fight or flight response. Sometimes you can see the sweat. Sometimes children will actually tell you they're sweating, right? Are they yawning? When you yawn, there's increased cortisol levels in your body as you yawn. Do they seem fatigued? You could look at a xerostomia test, using the tongue depressor in the side of the mouth to see if they have a dry mouth. Okay, that would be another indicator. Or muscle tension. Sometimes I'm palpating muscles, but you don't always have to touch. Like the SCMs, you can see the tension. You can see kids that are so tense they're lifting up their shoulders, or kids who come in and they are holding onto their stomach or holding their head. When you're in pain, you're definitely not in rest or digest. Behaviorally, I would say, this is something you could be looking in your waiting room. You may be putting things in reports. Are these kids having temper tantrums? Okay, that could be a red flag. Are they irritable? Maybe having limited participation or refusing to participate in whatever you're trying to do. Okay, lack of motivation. Parafunctional habits. I can't not say this tonight, but non-nutritive chewing. Right? I had a mom one time come in with the kiddo who was definitely an Airway kid, and she told me he was chewing on the wooden shutters. So in some of my talks, I show these white wooden shutters. I mean, if that's not a red flag, I don't know what is. It's also a very expensive chew toy. That's literally how he was regulated. Right? That kids figure it out. They're chewing on their collars or maybe their shirt sleeve or their fingernails or toys or shutters. They know somehow intuitively their system needs to help them get into their parasympathetics. So anytime you see those parafunctional habits, I would always say that is a huge red flag. Kids who come in with a heightened sense of alertness or just being really vigilant, they may look like they have an exaggerated startle reaction to things. Okay, some of these things can be retained primitive reflexes, which are going to put them more in their sympathetics. They may have poor impulse control and hyperactivity. Okay. And if you hear things like my child's had a change in appetite or sleep, or they've become socially withdrawn or they're inactive, those are again red flags that we need to kind of explore or just consider this. Where's their brain right now? Because we want optimal timing for release and all these interventions we're going to do, but where is that child in their brain? Sensory wise, I'm sure like there's dentists maybe on this call tonight. They may steer away from touch from with objects, from people. You may notice when they're in a chair. You may notice as they interact with family. Avoiding eye contact and struggling with bright light. A lot of our feeding kiddos, you see avoiding certain food textures. Sometimes they're strongly just rejecting them, or maybe they're gagging on them. They may respond more to odors than other people, or cover their ears when they become frightened. And they tend to shut down and avoid social interactions. So a lot of these things, when I start talking sensory, and there is something called a short sensory profile for children 3 to 14, that if you have access to those and would say if you're using one, you should be using one with an OT on your team. Make the sensory integration referrals to your OTs. Okay, it's good for all of us to know about it, because if you have a child who has sensory issues, you're not going to be as effective with your interventions if you don't have some tools and ways to deal with those things when they come up. And then from like a language and communication standpoint, to see if kids are in limbic lockdown, if they tell you they're scared, please believe them, right? Or if you have a kiddo who struggles to just access what I call feeling words, whether it's their emotions or how they feel in their bodies. Okay, there's things you can chalk up to children not having vocabulary, but you'll know when children have vocabulary and when you may suspect that theirs is lagging. I always want to know what children notice about their bodies. So whether I'm putting in lemon, am I using a Q-tip or vibration? I always take things out, and I swear I must sound like a broken record, because I say to them, what do you notice? It gives me tons of information. A lot of my kids in their limbic systems aren't always noticing. Okay, you've got an extreme of that, which is another talk, but a lot of these kiddos aren't noticing. Okay. They may be reluctant to talk or engage in conversations. Often I've seen these kids look to their caregivers to speak rather than trying to engage with me, right? And think about, if you're running from a lion, which hopefully none of you are ever, that would be your fight or flight mode would kick in. And you're not going to stop and write a dissertation for somebody or read a book or write a novel, right? So children are going to you're going to see a difficulty putting thoughts together when they express themselves, or they may benefit more from simple yes/no questions, because that's really, their brain is just in fight or flight. That's how we all know we don't reason with 2-year-olds, right? They may talk excessively or ask you a lot of questions. And I will say that's a little bit of lucky for us that we see that, because typically that's an internalizing behavior from anxiety. Okay, so at least if they're asking you a ton of questions, or they're talking a mile a minute, they're talking about a lot of different things, that can be a good sign that they're in their limbic systems, they're having some anxiety. You might pick up on the fact that their voices change. Maybe they're really quiet, or maybe their voice gets shaky, or maybe they even lose their voice. They can become disfluent. Nonverbal language, kiddos may avoid eye contact. Okay, you may, I see kids like touching their face, touching their cheeks, rubbing their foreheads. They might be doing something on their clothing, right? Some of that, the posture. They may tend to turn more away from you or hold their arms crossed. Some people just do that because it's habit. It's how they feel comfortable. So don't take any of this as they're definitely in their limbic system. It's just giving you some things to think about. Compressing the lips, lifting shoulders. I call this turtleneck when they do this, right? Or rubbing and stroking their hands. Interestingly, if you want to know the experts, I feel like on nonverbal language, it's the FBI. You can read some of their information on this stuff. If any of this, what we've just covered, is of interest, I wrote an article back in, when was it, 2017, for the ASHA Leader called Climbing Out of Limbic. So that will, if you want a little rehash of tonight or some more information, you can go there. So one of the things I think I've come to as a provider is, I think we all need the release. The release before the release is actually all of ours. And for those of you know me, maybe you think I've just fallen off my rocker. I've just totally lost it. But I promise you, I don't think I have. For the simple fact that we need to release our timelines, and we need to release our outcomes. I think that's the release that needs to happen before kids get released. And when I say that, I don't mean that we release our protocols, that we don't use them, that we don't set short and long-term goals. But what I really don't like to see is sometimes that rigidity in following a protocol. Because when we do that, we literally miss the kid in front of us and where they are in that moment. And we know as therapists that children can change from 1 minute to the next in a session. They can change from 1 week to the next. And so I think allowing that child to kind of be our GPS is really important. Just look at the child in front of you and figure out where they are in that moment. When we look at timelines, it's really going to be determined, as all of you know, by the individual needs of the child, and I will say their family. Okay, so the essential factors we're going to go over tonight in timing for release are not just going to talk about what we know about kids, but what do we know about the family unit and the environment. And we do, in this timeline, want to look at principles of neuroplasticity, right? By giving them more time with us in therapy, we're giving them more practice, again, to create new skill sets, new patterns, new habits. We're also, they're learning, they're getting an investment, and they're learning, there's a buy-in. You know, I don't know, when I was a little girl, I remember putting something on layaway for my mom and giving money towards that over time. And it really mattered to me because I kept putting this effort in. And so I was really invested in the outcome because I kept working for it, but I was given the time to do that. Okay. I also think we need to factor in the honeymoon stage with kids. Maybe some of you experience this. I know I certainly have, where they come in for an eval and it's like, oh, okay, there we go. That they're just cooperative. They're really cooperative the first 1 or 2 sessions. And then all of a sudden that honeymoon stage is gone and their doppelganger appears and their real behaviors come out, right? As soon as they get comfortable with you. So if we go too fast, we don't get the opportunity to see children in different settings or over different periods that are going to show us who they really are. And we're also not going to see how families deal with the real world. Because how many of you have, like, you've had patients come in and they've had all kinds of circumstances that were unexpected that can completely sidetrack your therapy, right? So when you have that time with them, you get to see, is this the family that's really here? They're resilient, they're hanging in, they have supports to deal with these things or not. Okay. So the only thing I'm going to say right now in mouth space is, and I will tell you why I am saying this, because if anyone knows me on social media, I don't shout from the rooftops. And this was a situation where I could have shouted from a lot of rooftops. So what had happened was I was talking with a mom on the phone of a 3-year-old who had 2 releases as an infant. And this mom was a major historian. I mean, she had everything down that she remembered. It was also very traumatic for all of them. And during the pandemic, the child was treated on telehealth by a therapist. And when the therapist was able to see that child in person, they could not get in the child's mouth. And according to the parent report, so again, guys, this is just a parent report. Like, this could totally be wrong, but if this happens, let's just go with it that it might, because this is something that's important. The parent was told that the child had hit a wall and they needed to go directly to the release provider. So what I hope you'll all take away from today, if you don't hear anything else I said, is if a child will not open their mouth for you as the therapist, for you as a release provider, and for whoever is in their house that is going to be doing all of the post-care and the myofunctional therapy, whether it's a parent or a nanny or a grandma, if they will not open their mouths, guys, they are just not ready for release. Please, please, please don't do it. You've got to dig deeper. You've got to look into this. That is not a kid who's ready for release. And we're going to all set ourselves up to fail. And none of us want to see that. So when we think about release timing and tools to communicate, we can make questions that I'm going to share with you guys part of our intakes. We can also ask them again as part of a progress or a check-in to see where parents are, and you can send these home, and we can share them amongst our teams. If you get this information, share it, right? Share it with the release provider. If you're the speech path and the myofunctional therapist, share it with the PT, share it with the osteopath. Okay, whoever is on your team, even if it's an email or you need to do it on the telephone. So when I look at essential factors, I look at environmental factors. And I think some of this, guys, you're going to be like, Nicole, we do this. And if that's the case, then this will just be a review and it'll just be a validation, like, guys, keep doing it, right? Again, these were the things that I came up with when I thought, what can I do as a provider on an interdisciplinary team for these kids and families to help set them up for success? And in reality, there's only so much we can do to prevent things from ever going sideways, but it's just about giving it our best effort, right? So I asked them specifically about their time investment. And what I mean by that is, what is their outside school and curriculars? Okay, how open is your child's schedule for participation in a home program? Because remember, sometimes people get really excited to do this, and for 2 weeks, they'll make accommodations, and then all of a sudden, we have too much going on, right? And when those kids break like that, then there's a sense of failure, like, I didn't do it, I left, I didn't get it done, okay? Asking parents, how much time can you give each day to doing this program, this home program? So I try as a therapist to embed a lot within natural activities. I get a lot of feedback to know, did I give them enough? Was it too much? Because I want to know the gauge, right? And I also want to know how many days I can give homework. I never tell people they have to do things for 7 days. You know, adults don't go to work for 7 days. I don't think kids are going to do our stuff 7 days either. If they want to, great. Don't discourage them. But in reality, 6 days is great. If they ended up with 5, okay. Teamwork. How willing, once you finish an evaluation, or actually I've even started doing this in intakes now because it's just better to put this up front in the beginning. How willing are families to work in a team? Right? Because we know that none of us do this on our own. And parents oftentimes come to us, and when we're making connections of what's going on with these ties, and they're learning things for the first time and how to connect to pieces in the body, they can be blown away, like, wow, I thought I was just coming to you. I didn't realize I might need a dentist and an ENT and the osteopath or the cranial sacral therapist or the physical therapist or the OT. So you want to know that. We also want to know, what are a parent's views on pain management, right? It is not in my scope to prescribe medication of any kind. And I don't work with families on pain management, but as part of their team, I want to know, because I've run into families. Look, everyone has different views. And if we have a family whose child has so much pain afterwards that they will not engage in our practices and our therapies for those 3 weeks, then maybe we might have been better off not doing a release, right? Especially if that scars back down. So I think it's really asking parents and putting it out there. What do you do typically for pain management in your child? Who do you work with? And then advising them to go back to the pediatrician, or maybe they use a homeopathic doctor. And if you have concerns, reach out to the release provider and let them know they need to spend more time going over their recommendations for pain management post-procedure. And then life circumstances. Do they foresee any barriers that may prohibit their access to care? That could look like insurance reimbursement, or what kind of financial funds they're going to have to kind of keep going through things. And then just major life adjustments. I feel like, and you guys, if any of the providers in LA here who do releases are on this, sorry, I know I've screwed up a lot of your schedules, but when a family has just had a parent who's had a heart attack, or a new baby, a new baby is coming, or they're transitioning to preschool, consider that when you're thinking about when's a good time to release. If they're coming up to a big school break and they're traveling, the last thing you want is something happening in their way and they don't have the release provider there for something that they may need, right? Um, neurorelationally, we want to, so looking at other factors, we may look at neurorelational and we may look at behavioral. So from a neurorelational standpoint, I kind of alluded to this earlier. You want to notice or know, do children notice their bodily sensations? Do they notice hunger? This goes back to interoception. Do they notice fatigue? Do they notice pain or feeling of a full bladder? And can they verbalize those sensations to you? And you want to ask a parent, if they're unable to verbalize, how else would they let you know these things? Okay, because you might be going to do something in the mouth, but children that are not aware, my next point is, does your child demonstrate awareness of their body in space? If a child is clumsy and they're frequently falling or bumping into things, or they lay on the floor, or they slam a toy into like the fence, they're getting lots of proprioceptive input. Well, that's helping them, get those signals as to where they are in space. So if they're having a problem with their overall body, do they know where their tongues are? How do they know where their tongue is in relationship to the roof of their mouth or getting their lips closed? You're going to want to ask parents, does your child demonstrate aversions to sounds, textures, smells, and movements? Okay. Do they need motivation to initiate tasks or complete them? Right? I don't know. I've had more parents in the last few months who've just said, I need you to give things that I don't have to be present for. Parents are so tapped out right now, and bless their hearts because they were all working so hard. So we're probably, at least I feel like I'm having to shift and really recognize what kids can do and what they can do independently to get some of these things done. So what motivates kids to complete tasks? All right. And in terms of caregivers, you really want to have that upfront conversation. Are you comfortable seeing your child uncomfortable? Right? So it could be discomfort in the therapy. It could be discomfort after the release. Are they okay with that? Because that is definitely a barrier and a very big obstacle to overcome when parents are not comfortable. Thank you, Sherry. I think I just saw your question at the bottom. Let's see, what else? All right, what tools, I would ask a parent, what tools do you implement to help children get through non-preferred tasks versus, or tasks where they struggle? So non-preferred, for anyone who doesn't know, are just things they don't like to do. And some of the things we do with them, they don't like to do. So does a parent at home already have tools in their toolbox to help their kids get through those things that they don't like to do? And if they do, have them tell you what the tools are. Okay. And I do ask parents, has your child ever received behavioral supports, or are you considering reaching out for any behavioral types of supports? Because that tells you a lot about where their system is as well. I had a little girl once who was 4. And her adopted parents were there for the pregnancy. They were there at her birth. By the time I see her, she's 4. She's pretty much the height of her adopted mom. And I will never forget the day that the dentist called me and said, "Have you seen the dad's face?" And I said, "No, but what are you referencing?" And she said, "Well, he has scratch marks all down his face." Right? So while I could work to get the function to a place to be ready, that was this example of a family. I gave them referrals. That really, this little girl was the one wearing the pants. And that's a tricky place, because again, the parents got to be in the parenting role after these releases and be able to work with a child, right? Especially, and if they're already struggling before a frenectomy, how are they going to get a kiddo to do things? How are they going to get them to comply and to manage these behaviors when a child doesn't feel comfortable? Okay, so behaviorally, asking parents, does your child consistently follow one-step directions for preferred tasks? How about for non-preferred tasks? Will they consistently follow routines at home or at school? Right? Do they exhibit frequent temper tantrums for their age? And if they do, how long does it take them to kind of get recalibrated and come back from that so that they can function? And in what situations does that occur? Okay, because you could have behaviors around all of these types of things. And if we don't ask and we haven't had enough opportunities to see children and exploring a little more about what goes on at home, then we miss that. We miss that piece that could be really critical. Let's see.
Nicole.
Do they have fears of aversion? Aversions to objects, situations, or people? Find out. Are they flexible or are they rigid in their response to the unexpected? Now, sometimes people think that that's just kids on the spectrum. It's not. Okay, when I say spectrum, I mean the spectrum for autism. So I recently had a little boy who came in, and he was one of those, well, I'm only doing something once. He's the one that we had the brain discussion. But he was very resistant to use a tongue depressor. I don't put things like this in my mouth. Putting a Q-tip in his mouth, I guess they put his in his ears because that was like totally unexpected. And we went through why I was going to use a Q-tip, why I would put lemon on certain parts of his tongue. And so he was rigid and he was trying to control everything I was doing, which was a red flag. Gosh, he's got some anxiety there, right? That's the cingulate gyrus in the brain when we can't gear shift like that. And you can see it in kids who are not on the spectrum. But what I want to say is if you have a rigid kids aren't ready to be released. Okay. And are the kids you're working with, ask a parent, are they willing to try? Will they make mistakes? I have kids in therapy longer before release when that's how they come in. Okay. And there are kids that are frustrated. The brain takes the path of least resistance. So I don't believe there's lazy kids. But I think as a closing, because I know 6:02. Okay. I would just say to all of you, just hold this space for these kids and slow your pace, because it's really nothing that we're doing is a race. Unless you've got some kiddo that's not on the growth chart, that's got really bad obstructive sleep apnea. But even then, they're going to have other factors that are still going to require you to slow down and take your time. So I admire everything all of you do. I think this circle and this space is such a great place to be, to just optimize patient care. And thank you guys all for what you do and for having me here tonight.
Oh my goodness. Angela is right. We could listen to you all night. Thank you so much. And if you guys didn't know, Nicole is one of our advisors in our board. So we're so happy to have you here talking to us tonight. You're getting so many hearts on Facebook right now. We have had some amazing people comment. Chris Zombeck says, being a therapist is more than just exercises. Lael said, you are a blessing to this field. Emily had a question. How do you deal with kids with a needle and procedure phobia for release? That's Zoe. I say the word tongue tie, she freaks out.
Okay. So I think that may be addressed by a team, right? Sometimes I've seen release providers that will let kids come in and start touching some of the tools. But look, there's lots of things. You could, first of all, when you have those discussions, it's going to depend on a child. If a child is going to ruminate on that information, you don't want to tell them 2 months in advance, because for 2 months, that's all they're going to think about. So you have to be very individual in terms of what information a child can take. But, you can do things with stuffed animals, with dolls, with puppets. You can talk about how sometimes we feel something and it's just for a little tiny second. And, ask them to give themselves a pinch. So see it really fast. And we do that so that everything else we're doing feels better and feels okay. So practice, you can show pictures, use their toys. I don't know if that helps. Those are just some ideas. And again, I have great release providers around me who've been really wonderful with helping kids just feel comfortable at the doctors or the dentist for stuff like that.
And Michelle Emmanuel is here. She said, as mentioned, sensory processing differences are prevalent in this population. Get connected with your local occupational therapist. And if you don't know one, join the Airway Circle and ask over there in our Facebook group if there's an occupational therapist around you. We are restructuring the way that we do Circle Time. Circle Time is our study club that we meet once a month. We're making it a little bit longer because we talk so much and we share so much. So it's probably going to be about 2 hours now. And we like to have that small group. So the numbers are limited. We all usually only open once a year, but I think I'm going to open once more for anybody else to come in and then close it again. But we're going to have a small little board just for Circle Time. And one of them is an occupational therapist. We have Ruth Bork, who's been with us. We love Ruth, and she's going to be able to be there listening to cases, and you can present your patient questions. I'm seeing a patient like this. What do you see? Show videos, show pictures. It's very private, our group. We also have a messaging encrypted platform that we use now to communicate, and you can share as long as it's you're authorized to share in a study group setting your patient information. Then we can all kind of chime in and learn from experience, learn from each other. And then the second advisor that we have there right now is Christina Bridges. Christine is absolutely fantastic. She's a dental hygienist, myofunctional therapist, and she's almost a massage therapist also. And then the third one I will release later to you guys, but super exciting. So we have a Circle Time coming up Tuesday. It's always Tuesday, third Tuesday of every month at 8 p.m. And we have a surprise special this Friday, the 22nd. It is a live recording of our podcast with Nicole Goldfarb again. It's called Airway Answers. And she's going to be interviewing Dr. Bill Heng. You do not want to miss it. It's going to be at 6:30 p.m. Eastern Standard Time on Friday the 22nd. Mark your calendars. We are adding the event, the link on Linktree soon for you guys to register for that. And then on Thursday, we have Dr. Kevin Copleston. Very excited to listen to him. We have some amazing lives coming up this next few weeks. Does anybody have any questions? Angela, how are you feeling there, Angela? I'm trying to talk so you don't have to.
Thank you, because I'm just going to cover my lip when I do. So
it looks really good, though.
Oh, thank you.
Now looking at your live, I can really tell how your face changed.
It has changed a lot. It's still really tender, not really tender, but it feels very stiff. So it's I look forward to seeing it heal more, so that I can show more pictures to everybody too, and share my experience with my frenectomy here.
There you go. We're gonna share that on Circle Time, so you guys join us if you have not. Jen said, "Thank you so much for looking at children as a whole person with so many nuances, so much helpful information." Dr. Tuesday said, "Thank you for sharing such invaluable information. What are your thoughts on using papoose boards doing dental procedures?" Great question.
Jeez.
In the dental office, just tie them down, hold them up, and let's get this done.
Wow, I think that is a really layered question. I don't believe I've had experience with people using those. I don't know. Maybe there's somebody else who has a better answer than I might. I think that's something I would need to give a little more thought to. It's not something that jumps to my head. But I also understand that you don't want to be wielding a laser and having a child move all over.
Mm-hmm. Exactly. Safety first.
And I can't, speak for releasing providers and what's in their scope in terms of, what they should be doing. The only thing I ever do, and Michelle, you can jump in, is I talk sometimes about putting weight on kids, which in a dental office could just be the apron that they use when they x-ray, because, right, you're going to kind of calm the system. And again, not trying to be an OT, to tag team off what Michelle said, please guys, if you see some of those red flags for sensory processing differences, get in touch with your local OT. I would say just become besties with them, because I know for me, I've practiced a lot with them over the years. You collaborate. It's going to help you really address the whole child and just to honor their system. And it will help you in the areas you work in to get further along.
This is very important for us to talk about, because as a dental hygienist, I had all those patients that were airway. I had all those patients with sensory issues, and I never knew. I never knew what I was looking at. But some dental offices now do have weighted blankets already there for the kiddos. I think that's such a good idea. What else do we have? Do you want to talk, Angela? Where can I find Nicole's full text article? If you send me the link, or I'll find the link and I'll post on Airway Circle Professional. By the way, we have 2 Airway Circle groups. One is for professionals. The other one is for patient questions. If you're a professional, you're welcome to join both, but just know that the professional questions we keep on the professional only group. Michelle said, great talk. Thank you, Nicole and AC. You're so welcome. We love you, Michelle. Climbing out of limbic article. I'll make sure that you guys have that. Sharice,
it's also it's also on my website on allspacetherapy.com. You can go directly to the link there.
Perfect.
Perfect. But I'll send you something, Renata, to share with them.
Perfect. I'll just share your website. Thank you for being here and sharing with us. This is great information. We have a weighted blanket for some kids and adults. They ask for it now when they come in. That is great. Awesome. Oh my goodness. We seriously could stay here all night and listen to you. You're absolutely amazing. You are changing so many things for this field. I have never quite seen somebody treat patients and look at patients this way. And I really do hope that everybody that's listening takes something from here and learns something from you, because we should all be looking at children this way. You are changing the way that we are going to be practicing for the years to come. So thank you.
Thank you, Renata. I think we're all changing practice. So thank you for letting me join in that. And there's this great quote. It says, I think it was Anthony Delgado said, we're all writing each other's stories. So I think we're all connected here, and it's quite an honor. So thank you guys again.
Yay, you guys have a wonderful night. We love you. Again, if you're not an Airway Circle member, join us. You get a discount for the collaboration peers if you are Airway Circle and AAPMD member. I posted about it today. Go look it up. And we'll see you guys on Tuesday for Circle Time. Mwah. Bye. Have a great night.
You. Oh, thank you.
Thank you. Thanks, ladies. Thanks, everyone. Thank you, Renata.